Everyone, I have another video for you guys tonight. Let's just get into it. This is a question, really. It's either you know this or you don't. It's not that high yield, but it's also not super low yield, where this is definitely a question that is possible to show up on your exam, and I think it's an easy question to get. So 64-year-old female, she undergoes total thyroidectomy. She has an uncomplicated procedure on post-op day 1. She reports that her voice sounds weak and breathy. So this is the main symptom she's complaining of. She denies any dyspnea. She's able to speak in full sentences. She's sounding 99% on room air, so we can assess that already her respiratory status is okay. Flexible laryngoscopy is performed. Which of the following combinations of findings and nerve injury is most likely? So let's just go through these real quick. I'm going to start off with the nerves and quickly look at what they do. So we have the external branch of the superior laryngeal nerve. The external branch provides motor sensation to the cricothyroid. Next, we have the recurrent laryngeal nerve. This is going to provide motor innervation to all the intrinsic muscles of the larynx except for the cricothyroid muscle. So the main nerve that controls the muscles that allows us to speak is going to be this recurrent laryngeal nerve. Okay, it also provides sensory innervation to below the vocal cords, but that's less important to know in this case, and especially for step 2, the main symptom they're always going to be complaining of is difficulty talking. Recurrent laryngeal nerve here, and then we have the external branch of the superior laryngeal nerve. So we kind of cut these off based off of the two nerves. I think that's step number 1, is try to eliminate what doesn't make sense in these two ordered questions, guys. Always eliminate whichever one you think is going to be easier to identify. So we don't think it's an external branch of the superior laryngeal nerve. What would happen in these patients is a patient who is not able to control their cricothyroid muscle. They're going to be able to speak normally. They're just not going to be able to produce high-pitched noises. So for example, if they say a patient is not able to shout, not able to raise their voice or control the pitch of their voice, but they can speak normally, then that's going to be an external branch. So we can eliminate E and we can eliminate A, and we're stuck with the recurrent laryngeal nerve, and that is on par with her symptoms. You know, she's weak, her voice is weak and breathy. And so next question is, what is the laryngoscopy going to show? One vocal cord fix, or bilateral vocal cords, or normal vocal cords with inability to reach high pitch? Well, this one right here is wrong, because this is what would happen if we had an external branch. So this answer here is wrong. Cross off D. We're left with either one vocal cord or bilateral vocal cords. So the main difference here, guys, if bilateral vocal cords are fixed near the midline, meaning both these vocal cords are closed off, that means we can't really breathe. There's no room for air to cross here, guys. This is a very small margin, and so she's gonna be having respiratory symptoms. She's gonna be having difficulty breathing. We don't see that in this case. She denies dyspnea, so it's not going to be bilateral. It's going to be B. One vocal cord is fixed in the paramedian position, which is going to look something like this. One of them is fixed, and then the other one is open. So we have good amount of air to go through that trachea and to breathe. And so quickly, I just want to go over this pearls about laryngeal nerve and hoarseness. Anytime you have a patient with hoarseness, these are the main presenting diagnoses. A patient after thyroidectomy, this is very classic. Think of a recurrent laryngeal nerve first, and that's because if you see in this picture right here, this is the vagus. It courses down. The vagus continues down, and then there's a branch. This branch right here that goes below the aortic arch, that's going to be the recurrent laryngeal nerve. It's going to come up and go behind the thyroid. Okay, so it's right here. So anytime they're going in, obviously, to take out the thyroidectomy, you can imagine they might accidentally, take out this nerve, and that's why they have a probe in the OR checking to make sure where the recurrent laryngeal nerve is, and that's a big problem if they lacerate it during the procedure. And so main symptom here is, unless they say they can't hit high notes, then you're going to think of the superior laryngeal nerve. But by default, guys, thyroidectomies associate them with recurrent laryngeal nerve first. Okay. Carotid endarterectomy, think of a vagus in the carotid sheath. And so also think of symptoms that causes hoarseness, dysphagia, plus uvula deviation. You're going to see a few more symptoms related to the vagus nerve injury. And really quickly, here's the carotid sheath. This is the internal jugular. This is the common carotid. Okay, and then this right here is the vagus nerve. It goes between the two. And so over here we see this nerve coming down, we would expect the IJ to be somewhere right here. But if an injury occurs somewhere around here, unrelated to the thyroid, we can imagine that before it branches off the recurrent laryngeal nerve, if it's lacerated from right here above that branch, you're going to have more broad symptoms related to the vagus nerve. Next, we have aortic aneurysm. This is classic, guys. You see how the recurrent laryngeal, it literally goes below the aortic arch, wraps around it, and then comes back up. Obviously, if there's an aneurysm here, it's growing, it's going to eventually impinge on it and then cause the same symptoms actually over here as a thyroidectomy. And then lastly, we have the lung apex. This is recurrent laryngeal nerve. Look for other signs like Horner syndrome, shoulder weakness and slash pain, and then of course a smoker. So 35 years of smoking, and they mention anything like recurrent laryngeal, automatically think of lung apex mass. And then quickly, so the patient is, if they have breathy or weird voice, that means one cord is not closing. This is a unilateral laryngeal nerve palsy. So we see right here, we still have enough air to come in. That's because one of the sides is still able to open so that you can breathe. Okay, so there's good air. If they say stridor automatically associated with both cords not opening, and that means it's bilateral. Okay, if they say stridor or they mention a low oxygen saturation, that means it is a bilateral lesion, and you can see that right here where essentially there's not that much room for air to come in and they're going to be in respiratory distress. So next up we have, these two symptoms are definitely on the lower yield end, but once again, my channel really is for those who want to score in the 265 plus, 275 plus, and if you really want to and are serious about scoring those high range scores, you're gonna have to know everything. I mean, these guys can literally ask you about anything there is in medicine, and so you just have to know this stuff. This is like something where you can just listen to it while you're driving or anything like that. But essentially, really quickly, external superior laryngeal nerve. This is motor function to the cricothyroid muscle. Damage to this is just going to basically say they're going to describe a patient who can speak normally. They're not going to mention breathy or weird voice. They're just going to say that that patient cannot shout and he loses high-pitched noises. So look for that. And then if the patient is choking on liquids, aspiration, loss of sensation, you can think of sensory loss above the vocal cords, and that is the internal superior laryngeal nerve. Okay, so the superior laryngeal nerve is actually going to branch off up here, and that branches into the internal and external. Okay, so we have, this is the vagus, we have the superior laryngeal nerve, SLN, that's going to branch into the internal and external. Okay, and then we have the vagus coming here, and then the recurrent laryngeal nerve is going to come up from below. Okay, so really quick, last few seconds. This is the algorithm I want you guys to take for any time there's hoarseness in a question stem. Is there stridor? If it's yes, it's bilateral RN. If it's no, then you ask, is the voice breathy? If it is breathy, then it's going to be a unilateral RLN lesion. And if they can speak but they can't shout, external. And if there's aspiration without voice change, internal SLN. And that's it.